Good afternoon all. Thank you all for joining first of all. It's obviously taking time out of your days to attend this webinar. I hope it will be useful of you. You may have seen or heard something about the CQC scrapping its single assessment framework. There's been various news items and articles released by the CQC on this over the last couple of months. And you may understandably be wondering what that means for your practice. So the short answer is nothing changes today. It's nothing to panic about right now. But there is a lot of things changing behind the scenes. CQC are working through their frameworks at the moment, and they're currently trialing a new draft framework, which we'll look at today. But there is nothing immediately changing right now, so no need to panic. I'm Rhys Jones, Head of Compliance at Agilio, and over the next 40 minutes, I'm going to talk you through what is coming, what this new draft framework looks like, and what you need to be prepared for. So during the course of this webinar, we'll be looking at various topics. We're going to be looking at why the Single Assessment Framework, or SAF for short, is being replaced, what the SAF is being replaced with, what's inside the new draft framework. We'll have a look at the Key Lines of Enquiry, KLOEs, that you may be familiar with, and we'll look at how we, Agilio, responded to the CQC consultation regarding their new draft framework. And then we'll quickly go over then what you as practices need to be prepared for and how you start, what you need to start doing to get ready for this new framework to come into place. So first of all, why is the single assessment framework being replaced? Well, initially the SAF came out. It was intended to be a much simpler framework, one framework for all healthcare providers. It was supposed to give inspectors more freedom to go and to address the inspections, to enable them to do a lot more of the inspections in quick succession. However, that didn't work. There was 2 independent reviews of the SAF in 2024, and unfortunately, they found that the framework wasn't fit for purpose. So there was 2 main reasons that came out of those reports. It came down to a design flaw. One universal framework for all healthcare sounded good in principle, but it just wasn't practical. The differences across all healthcare providers was too vast for one framework to work. It also resulted in confusion within the CQC themselves. Not even their executive team really understood how the single assessment framework was to be applied across all these different sectors. So principle was there, one framework, much simpler to implement, but practicalities just didn't work, unfortunately. And also, it was built on a lack of expertise. They brought in inspectors who had a vast general knowledge across sectors, but there was no specialized knowledge within each sector as well. So that has changed. The CQC has recruited a lot of independent specialists into their new framework at the moment, and they're going to be applying that knowledge across the various sectors that they're going to be looking at under the new frameworks. And also then something that we've seen internally here at Agilio. Every month we look at 10 CQC reports. We look at those that are failing. We look at the reasons why they're failing. And we identified as well that the single assessment framework was being applied across dentistry inconsistently. So what that means is altogether there was 34 quality statements, they call them, 34 statements that the inspectors would be judging healthcare providers on. However, in dentistry, only 7 of those 34 quality statements were actively used, and we can see them there on the screen. So the top 7, safe environments, infection prevention control, governance management, safe and effective staffing, delivering evidence-based care, kindness, compassion, and dignity, and then equity in access, were the same active quality statements. Safeguarding medicines optimization since the start of the year, there's only 1 report that we've seen that had those covered off as quality statements within them. So safeguarding, even though there was a designated quality statement for it, within dentistry, they were assessing that under the quality of statement, safe and effective staffing. And with medicines, they were looking at that across various quality statements. They were looking at it across safe environments and delivering evidence-based care and treatment. So we can see the inconsistencies, 34 quality statements, but not all of them being looked at within dentistry, and some of them being shared across multiple, whilst there was specific quality statements for them. So again, this goes into what the inconsistency with the framework, it just wasn't working effectively. You look at the HTML reports online and it does list all 34, but we can see here that only 7 were being looked at. So very inconsistent framework that just wasn't practical, as I've already said, and just didn't work for us as a dental sector, as well as other providers out there. So the main thing that came out of the independent reviews was to review the SAF to make it fit for purpose. So essentially that's what the CQC have done. They've gone back to the drawing board. They've looked at how they can create a new framework for the various sectors and how that could work. So what is the SAF being replaced with? Well, they're replacing one single framework with 4 sector-specific frameworks. So the first one they're replacing it with, they're doing a designated framework for the adult social care. They're doing one for mental health care. They're doing one for hospitals, including secondary and specialist care. And they're doing a 4th one for primary care and community services. And that's where dental will sit. So we're going to belong as a sector under the primary care draft framework. So we're not going to look at the other frameworks. We're going to focus on the primary care framework for the purposes of this webinar. So what does this new draft framework consist of? Well, first of all, they're keeping the 5 key questions. So we're all familiar with these. They've been in existence across all previous frameworks, even the one before the SAF. And that is still the key questions that they'll be asking. Is your practice safe, effective, caring, responsive, and well-led? So no changes to these. They're keeping them in place. What's going to fall under these key questions then are the key lines of inquiry. So they're bringing those back in. For people here who were around before the SAF was introduced, this is how they judged dental practices. They used something called the key lines of inquiry. These were scrapped, replaced with quality statements under the single assessment framework. Now they're going back. They're scrapping the quality statements and reintroducing the KLOEs. So there's going to be about 3 to 7 KLOEs per key question. And we will look at those in a bit more detail later on in this webinar. They're also then going to be keeping the rating characteristics. So these exist at the moment. There'll be rating providers and judging them whether they're outstanding, good, requires improvement, or inadequate. So the new draft of framework is built around these. These are described as the mechanism by which inspectors will make their judgments. However, dental services are exempt for ratings. So outstanding, good, require improvement, and inadequate will not apply to a dental practice. So again, we'll look into that a little bit later on in the webinar. And then finally, they're keeping the I statements. So these were brought in under the SAF, and they reflect what people have said matters to them, so the patients. So every key question will have a set of I statements. An example there, I have considerate support delivered by competent people. That's what the CQC expect the practices to deliver based on the feedback from the service users or patients. So another example under the effective key question is I have care and support that is coordinated and everyone works well together with me. Inspectors will seek assurances that the services being assessed reflect these statements. So they will fall hand in hand with the rating characteristics for the inspectors to judge their opinion on how these services are providing care and support. So together, these 4 components form the quality indicators, and these are a legal requirement under Section 46 of the Health and Social Care Act 2008. So this is what the new draft frameworks are formed on. 5 key questions, reintroducing the key lines of inquiry, judging them around rating characteristics, but that will be different for dental practices, as I'll go on to explain later on. And then I statements, what patients expect service providers to be doing. So the new framework, a very quick overview before we look at the KLOEs in more detail. So we got the 5 key questions. We've got the current quality statements and the number of them that are currently being assessed on. We've got the new KLOEs being brought in, and then we got topic areas. So we can see that under the safe key question, they're reducing the number of quality statements from 8 down to 7 KLOEs. And under those 7 KLOEs, they're going to be looking at 41 topic areas. So that's your evidence. That's what inspectors will be looking at you providing as a service provider to demonstrate that you are providing a safe practice. Under effective, they're reducing the quality statements down from 6 to 5 KLOEs. And again, they'll be looking at 22 individual topic or evidence areas under that. Caring, they're reducing down from 5 to 3 with 10 topic areas. Responsive, down from 7 to 4 with 13 topic areas. And then well-led, down from 8 to 7 with 36 topic areas. So they have done a reduction. They have simplified the framework. They've tried to reduce the amount of information that they're looking at when they come to inspect. But they will still be looking at a lot of the evidence they currently do. In total, 122 topic areas altogether that we'll be looking at. So again, don't panic too much about this right now, because the majority of the topics and evidence they'll be looking at will not change. There's a couple of new things coming in that I'll explain in a little moment, but the majority is going to be all the same as what you're familiar with right now. So looking at the KLOEs then. So the first key line of key question is safe. And under the key lines of inquiry under this, you can see the difference between the SAF that's currently being assessed with the new draft framework that's coming in. So there's 7 key lines of inquiry under safe, and the majority of these haven't really changed from the SAF. They've tweaked the language, they've tweaked the terminology, but they're kind of the same framework that's already there. So safety culture was previously learning culture. So it's the same thing, they just tweaked the language to make it clearer and more precise. Managing risks during during care and treatment was previously involving people to manage risks. So again, just trying to make it a little bit clearer to what they'll be looking at. Some of them haven't changed at all. Safe systems, pathways and transitions and safeguarding, exactly the same. So you can see this is all about tweaking the framework, trying to make it more clearer, trying to make it more precise, looking at the wording around the KLOEs and the current quality statements, getting rid of any ambiguity that may exist. And what they have done as well is, rather than reducing it, I'd say they've probably done more of a consolidation exercise. So we can see here under the current safe key question, they've consolidated the 2 current quality statements, safe environments and infection prevention control. They've consolidated them into a single key line of inquiry, which is number 5, safe environments and infection control. So whilst there was 8, there's now 7, but 2 of them two of them still exist, but as 1 instead. So the sort of topic areas they'll be looking under this. So again, this is going to be the same things that you are familiar with, accustomed to right now. But under safety culture, they're going to be looking at raising safety, how you raise safety concerns and manage them throughout the practice. They'll be looking at your responsibilities under duty of candor and how you manage incidents in the practice. So your accidents, incidents, how you report on them, how you feed back to the staff about them and how you learn from them. Under number 2, managing risks, they're going to be looking at how you manage medical emergencies, how you manage clinical risks, and how you manage your clinical records. So again, you should already be familiar with this. These are the sort of things they look at currently. Under number 3, safe systems, pathways, and transitions, they're going to be looking at how you share information across your teams and across other providers as well. They'll be looking at how you manage referrals, and how do you maintain your continuity of care if there was issues such as flood, power failure, or anything like that. Number 4 it is, as it says on the tin, safeguarding. So you're going to be looking at your processes around safeguarding, your training, how you manage that, how you refer to the relevant support agencies for safeguarding concerns. But under that as well, we'll be looking at topics like harassment and victimization for your patients, protection of human rights and how you avoid discriminating against your patients as well. Number 5 then, safe environments. So that's all about your premises and equipment. How safe is it? Have you got your maintenance records in place? Have you got your risk assessments in place? How are you embracing digital systems? So, we live in an environment, in a world now with AI coming into play. If you're thinking about using AI in your practice, they may start looking at that as in relation to safe environments. And physical safety as well. How do you maintain the physical safety of your premises and also the staff as well? How are you protecting them from physical risks, violence and aggression from patients, from other staff members? Number 6 then, safe staffing. So under this, they'll be looking at your workforce in total, your recruitment procedures, your staffing levels. Have you got a sufficient cover in place to ensure that safe care can always be provided at all times? They'll be looking at your skills and qualifications of your staff members, how you performance manage your staff. So if there's any concerns, how you were managing that, how you were addressing it, how you were keeping your staff members engaged. And also then with regards to agency staff, if you are using agency staff, how you are ensuring that the relevant checks are in place to make sure that those staff have got their DBSs in place, that they're appropriate to come into your premises and support your patients. And then safe delivery of treatments and medicines. That is all how you are managing your medicines, how you are prescribing them, how you are managing your medical gases if you've got them in place, how you are storing and disposing your medicines, how you using controlled drugs, and how you are overseeing antimicrobial stewardship as well. So there should be nothing new there that I've said. Those are all the sort of things that you should be doing on a day-to-day basis, regardless of this new framework coming into place. So the next CLOE then, under this key question effective. So we got 5 different CLOEs under this, under effective, a reduction down from 6 quality statements with 22 topics altogether. So again, very similar. Not a lot has changed. Majority of these are exactly the same as how the quality statements are listed right now. But you have got outcomes. They've improved the language around that one, just simplified it. And you've also see there at the bottom of that little table, how staff, teams and services work together has been relocated to SAFE and consolidated with SAFE systems, pathways and transitions. So what they've done is they've looked for possible repetition, duplication within the current quality statements and gone, well, this current CLOE is already kind of dealing with that, so we're going to consolidate that with that one instead. So how staff, teams and services has been relocated and consolidated. So again, we've seen a reduction as part of that exercise. So again, some of the topics they'll be looking at under these, assessing needs. So this is all about your accessibility and your communications, how you are providing those to your patients, how you are ensuring that their communication and accessibility needs are being met and addressed, how you are care planning effectively with them, so communicating with them regarding their treatment plans, their dental provision, and how you're using clinical assessment tools in practice to aid you with those communications and care planning needs. So delivering evidence-based care, that is how you are following your best practice guidelines. So there's lots of guidelines out there, HTML 105 and the various others. There's lots of guidelines from GDC. So how you are following those, how you are communicating those to your team, how you are ensuring that you are meeting what is required of you as dental professionals and as a dental practice as a whole. How you are undertaking clinical reviews, and are you part of any service accreditation schemes as well to really put yourself on that pedestal as a gold standard practice. So we could be looking at all those sort of topics under number 2. Under outcomes, that is how you are managing clinical audits. So what sort of audits are you doing in practice? Are you reviewing the outcomes of those audits proactively, or are you just doing them as a tick box exercise? You know, they want to see the outputs more than the tick box piece of paper. They want to see how you're learning from audits and what improvements you're putting in place. They're also going to look at whether you're doing peer reviews in practice and what sort of quality improvement activities you're doing as well. So again, you're learning and improvements. What have you put in place? What exercises have you done to address or identify any gaps in your practice, and what you've done as part of that, your action plans. Supporting people to live healthier lives. So this is how you are engaging with your local demographics, your population health and prevention. How you're promoting how to live healthier lives. So obviously in a dental practice, how you're promoting oral hygiene, smoking cessation advice, to try and help people quit smoking. It's part of your medical histories when you're obviously addressing their social activities, how much they drink, how much they smoke, what you're doing to encourage members to change their lifestyle to improve their oral health. And then identification of early health interventions. So again, oral cancer screening, what you're doing to manage that, and how are you identifying that, referring patients that may need support down that route. So they're going to be looking at those sort of topics under supporting people, Chloe. And then under consent, well, that is again your capacity to consent. What sort of knowledge do you have around that? How are you engaging with your patient base to ensure they've got the capacity to consent? And what sort of advocacy and support is out there then to help those patients understand the treatment options, understand the risks and benefits that you are providing them for the dental treatment that they need. And they're also going to potentially start looking at policies and processes around do not attempt CPR under consented care and treatment. So again, as part of I Comply, we've got our medical emergencies documentation covers off do not attempt CPR within it. But that's quite an interesting one that the CQC may look at. So that's something to be aware of. And then caring, key question. So we got 3 CLOEs under this. Was previously 5 quality statements. So they've done a bit of a reduction on this one. But we can see that they've consolidated some of the existing quality statements. They've moved them around under the new framework. So workforce wellbeing and enablement has been consolidated with person-centered care. Treating people as individuals has been relocated to responsive and consolidated with care provision, integration, and continuity. And responding to people's immediate needs has been again relocated to responsive and consolidated with listening and responding to feedback. So this one's only going to be a small key question, 3 key lines of inquiry, and the sort of topics they will look under this is how you are managing privacy and confidentiality of patient personal data. Are your reception areas suitable? Can people overhear conversations that you're having on the telephones? Have you got private areas to have confidential conversations with your patients? So they'll be looking at how you manage that. How you are supporting patients with emotional well-being. We know a lot of patients suffer anxiety and stress when they come to a dental practice. So what sort of support are you offering them to help them with that? What sort of things are you putting in place to make the environment a lot more inclusive for patients, especially around neurodivergent patients as well? So what sort of support and advocacy services have you got available to help patients on that sort of front? Empowerment and decision making then under number 2, person-centered care. So how are you empowering your team to be able to make decisions themselves? We are a team, an effective practice. We'll have effective delegation in place. We can't rely on a practice manager or principal dentist to be able to do everything themselves. So how are we empowering the team to do what is needed of them under their roles and responsibilities? And then how are we supporting the patient base then from a personal, cultural, social, and religious basis? So again, all our patients, and again, your demographics will vary wherever you are in the UK, will have different needs from the patients that come in. So how are we supporting, recognizing those needs, and what are we doing to put them in place? So again, they will be looking at those sort of things. But again, you should be doing those as it stands right now anyhow. And then under number 3, independence, choice, and control. It's again similar to the one before, supporting communication and choice. So again, patients have different communication preferences. What are we doing to identify those preferences, and what sort of support are we putting in place? Are we helping them by giving them access to friends, family, and community support services that were available? Are we allowing them to bring those support advocates in that the patients want? And then what sort of specialist adaptive equipment are we thinking about bringing into our practice as well to support patients? So we've got dental chairs of various weight capacities that we could consider. There's specialist chairs out there that can accommodate patients who are over that threshold at the moment. And we've got things like translation services and other supportive avenues as well. So what are we doing to help patients that can't accommodate our day-to-day services and needs? So responsive, the next key question. And again, key lines of inquiry down from 7 to 4 under this with 13 topic areas. So again, providing information has been consolidated with equity and experience. Person-centered care has been relocated to caring that we briefly touched on earlier. And planning for the future has been relocated to caring and consolidated with independent choice and control. So again, you can kind of see now what I'm talking about with it's not so much of a reduction, but a consolidation exercise to try and bring all these quality statements that exist into a much neater, tighter, I can't get my words out, tighter web of KLOEs. So again, under care provision, the sort of topics they will look at is continuity care, treatment, and support. So how we maintain in that continuity care if your practice had to close for a day of training or close because of a power failure, what sort of services or provision we got in place to ensure our patients can still access the care they need, but maybe at a buddy practice that you've got or alternative provider. Under number 2, then, that is your feedback complaints. What sort of processes have you got in place to deal with your feedback? How are you communicating that to patients? How are you showing them or demonstrating to them what you've done to listen to them and put things in place so that they don't think that they are being ignored? Their voice matters, and that's what they want to know, and that's the sort of evidence that the CQC want to see. So they're going to look at all your processes for managing feedback and complaints. And then timely and equitable access. So that is how accessible your premises is. Can it accommodate all forms of disability? And waiting times and delays, how are you managing those? You know, how are you communicating delays to your patient base? How are you offering them alternative treatments, alternative days in the diary if you can't accommodate their immediate needs? Or if the treatment that they have come in to see has overran and that patient needs to leave to deal with some personal errands. So are you proactively offering them because of the delays that have happened? Emergency care out of hours, how are you communicating that? Is that clear to patients through various channels? Is it on the websites if you've got one? Is it clearly displayed outside the practice that patients can see if they turn up outside normal operating hours? And what sort of reasonable adjustments are you putting in place as well to accommodate patients? So again, are you doing your disability access audit to identify where you can make improvements in your practice? And have you got an action plan to show to the inspectors that you are putting these improvements in place, whether that's been changing the height of the reception desk, having a variation of seating chairs in your waiting area, some with arms, some without arms, different sizes, different heights, you know, so lots of things you could be doing. That's the sort of thing that CQC want to see evidence of. And then number 4, equity and experience. So again, it's similar to the one above, timely and equitable access, barriers to care, accessibility, transparency in communication. So things like translation, interpreter services. So whereas the previous one was more about the physical environment, this is more about your written matter and how you're communicating with your patients. So Braille, large print, all those sort of things. How are you providing your written matter and your communications in a format that your patient base can understand? So again, this isn't just about disabilities from this front. This is about a variation of your patients, and they may all have different communication needs. Some of them, their first language may not be English. So what sort of interpreter provision have you got to accommodate that? So the last one then, the key question, well led. This is a big key question at the moment. This is fundamentally where a lot of practices fall down on, which we'll go into in a bit more detail. So this has got 32 topic areas and 7 KLOEs. It was originally 8, so they've reduced it by 1. But you can see there, freedom to speak up was previously a quality statement, but they've consolidated that with workforce equality and culture. And environmental sustainability has been consolidated with strategic direction. There is one thing to note on here, number 5, management of risk, performance and issues. That is a brand new key line of inquiry that's been brought in or due to be brought in under the new draft framework. So that never existed under the single assessment framework before. And we'll have a look at that in a bit more detail on the next slide. So a couple of topics that they'll be looking at under this one is organizational and environmental sustainability. So obviously we're living in a world now where it's a lot about reducing the carbon footprint. The governments across the UK have released their mission to be net zero by 2050. So what are we doing as a practice, as a sector, to contribute to that? How are we reducing our carbon emissions? It was something that the CQC were due to be looking at in the dental environment under the SAF. It didn't come into play initially, but now it's going to start coming into play under the strategic direction, key line of inquiry. So again, don't worry about that too much just yet, because we don't know exactly what their expectations are going to be around it. And you may already be doing things based on it as well. The way you are purchasing your supplies and that, going down the greener route. Your waste is a big one. The HTMO 701 that came out last year was all about transitioning across to the offensive waste stream to, again, reduce carbon emissions. So you're already going to be doing things around this in practice anyhow. And there may be other things as well. Your light bulbs, have you got low efficiency light bulbs in place? So lots of little things that you may be doing. They're just going to be looking at that in a bit more detail. And then number 2, workforce equality. So whereas in the previous key question, it was all around patient equality, they're going to be looking at your workforce equality under the well-led. So again, discrimination, bullying, and harassment, more to do with your staff. How are you preventing that from happening with your staff to ensure that they are motivated to come to work, that their levels of morale are high, because that all then enables them to provide a better service to your patient base. They're going to be looking at your speaking up culture. So again, have you got an open door policy? Are you welcoming feedback from your staff members? And are you actively dealing with that feedback in the right way? So again, whistleblowing, your formal processes to allow staff members to whistleblow, and ensuring that they understand that they are protected if they whistleblow as well. So they'll be looking at your policies and procedures around that. And then general staff well-being. So have you got appropriate facilities in place for their well-being? Have you got somewhere where they can sit down, rest, have their food, their lunch, and all that sort of thing to keep their motivation levels high? Number 3, then, capable, compassionate leaders. So it all links into that. What are you doing as leaders of the practice to manage your workforce, to manage the patients? What is your competency levels like? How are you dealing with that? How are you communicating it with your team? Are you engaging them through team meetings effectively? Are you having regular performance reviews and appraisals or one-to-one meetings? So how are you managing all that all together? They're going to be looking at your fit and proper persons as well, requirements under the Health and Social Care Act regulations. So again, what sort of checks have you got in place to ensure that you, as directors or as the workforce, are fit and proper and maintaining your required evidence, your DBS checks, indemnity, all that sort of thing? And then talent management then. What are your recruitment processes around talent? How are you ensuring your team maintain on top of their CBD, their mandatory training? What are you doing to encourage further training that they may need and want? Team members, they should feel enabled to come to you and ask for further training. So what are you doing to encourage and help that? Number 4, then, governance. So roles, responsibilities, and accountability. Have you got a strategic organizational chart in place? Does everyone know what their roles and responsibilities are? As I mentioned earlier, a well-run practice has effective delegation in place. So you should have people like infection control leads, radiation protection supervisors, first aiders, fire marshals. Are those roles fulfilled? Do people understand what they need to do within those roles? Has that been communicated clearly? And are they comfortable taking on those roles? We do see as a business that roles are given to people or can you take that on for me, please? And it's not really communicated what's expected of them. When CQC comes in and asks then, who's your fire marshal? And then they ask that person, right, what do you need to do? The worst thing that person can say is, I'm not sure, I've been given this title, but I've been given no training on it. So that's what they want to look at under governance. How are you managing that and communicating it effectively? And then how all those roles are working together then to ensure that the practice itself is being well led. Under number 5 then, management of risk, performance and issues. We'll look at that on the next slide. Okay, so you won't go into too much detail now because it's a brand new CLOE. We'll have a look at that in a bit more in depth. So number 6, partnerships and communities. That is how you're working with local other healthcare providers as well, GPs, hospitals, and now. If patients are moving in between these providers, how are you ensuring that the information regarding that patient is being shared with them so the patient is not having to take that communication themselves and have the same communications and conversations with these other providers? So what are you doing to contribute to those partnerships to ensure that the patient journey is as efficient and supportive as it could be? And then number 7, improvement, innovation and learning. So this is all about how you're managing your improvements in your practice. What sort of audits are you doing? What sort of learning outcomes have you addressed from those audits? And what have you put in place to continually demonstrate to inspectors that you are learning from the audits, identifying gaps? And the one thing we've got to understand is we're not perfect as a society. We can always improve. I'm a believer that there is no such thing as perfection. If you do, that's where you run the risk of becoming complacent. There's always things you can work on to make better, especially as new technological advancements come out. AI, for example, at the moment. So how can we constantly embrace these enhancements to improve the services that we are providing? And that's what has been looked at under this CLOE. So looking at that new CLOE that's coming in then, well-led, management of risk, performance and issues. So at the moment, there's 6 topics underneath this. 5 of them are already included under the current SAF and will already be accustomed to being inspected in a dental practice. They are currently separated in various different elements of the current framework, but they've been consolidated into one place. The only new one they brought in is use of resources, and that was a direct result of the independent reviews that was done on the SAF. Use of resources is a requirement of the Health and Social Care Act 2008, and it was missed out of the single assessment framework. So it's been brought in under this new CLOE. So we don't know exactly what they'll be looking at underneath use of resources at the moment. What the draft framework states is that the service invests in innovative and best practice information systems and processes. The information used in reporting, performance management, and delivering good quality care is consistently found to be accurate, reliable, timely, and relevant. So that's what they'll be addressing or assessing you against under that use of resources. So essentially that means, are you using all those sort of technological advancements that are available to you to enhance your patient service? Are you embracing the move to digital over paper records, for example? Are you using potential AI solutions to help you with these sort of things? Are you using compliance systems to help you manage your governance of compliance? So there's loads of things, training providers, what sort of resources. That's the sort of things that we're looking at underneath this. How you effectively using what's available out there on the market to you to help you manage compliance in a dental practice. So what I've tried to establish here is why they've brought this new KLOE into place. And what I can see from the inspection trends that we do behind the scenes is that at the moment, dental practices are judged as not all regulations met or regulations met. So this is where those rating characteristics I mentioned earlier in the webinar don't apply to dentists. We don't get rated outstanding, good, requires improvement. We are judged simply as regulations not met or regulations met. And out of 50 practices that we did analysis of since January this year to May, we found that 45 out of 50 inspection reports that were judged regulations not met were failed on this well-led KLOE, essentially, or they were failed on well-led rather than safe. So only 11 out of 50 practices were failed on safe, 45 out of 50 on well-led. And the example of this is what came out in the reports, and this was quite common, was that even though practices were failing to evidence key safe evidence, such as gas safety records, fire drill, COSH risk assessments, or electrical testing, the inspectors were deeming it that these were more to do with the issue of the practice not being well led, not having those governance systems in place, than the practice being unsafe itself. So one of the comments that was coming out of a lot of the reports was, whilst these issues were present, our concerns relate to lack of governance and risk oversight rather than immediate patient and staff safety. So you could argue that, oh, you haven't got an electrical inspection certificate report on site. That warrants your premises as being unsafe. But they're taking more of a holistic approach on this. If you've got historic evidence that you've done these sort of inspections historically, and you may have just missed the most recent one, then they will go, right, okay, your practice was historically safe, but you've fallen down on governance. You've let things lapse. You haven't kept your eye on the ball with regards to when these things come up to expiry. You haven't got processes in place to ensure that your risk assessments are being reviewed constantly. So they're failing practices a lot under well-led. And they've brought this well-led KLOE in to put all that into one nutshell. Okay, so essentially they're going to be pulling that information off that they're currently doing at the moment, and where they're demonstrating where you're letting things slide, you're not keeping your eye on the ball, you're not routinely renewing your testing certificates or your risk assessments, they're going to be failing you likely on this particular KLOE going forward. So topic areas, we've touched them in quite a bit of detail when we looked at all the new KLOEs, and all the ones I mentioned earlier are things that you should already be accustomed to. They're already the things that the CQC inspectors look at as part of their current framework. So a couple of new topic areas that are going to be coming into play is more around staff diversity. So they're going to be looking at gender pay gaps, workloads. Are staff able to keep up with the demands of them? Is it fair between the different genders that work in your practice? So these are quite new things that are going to be coming into play. They're also going to be looking at staff safety as well. I'll go into this a bit more detail on the next slide. But essentially, this is now looking at your staff safety, not just your patient safety, which is what the CQC is predominantly coming in to do. Okay, so we've got no published guidance on this right yet. We don't know exactly what they're going to be looking at underneath these new topics, whether these are going to be policies, part of your recruitment processes. We're not quite sure just yet. They have promised that they're going to release further guidance before the frameworks come into play. So we're waiting for that at this moment. And once we have that information, we can provide more details on this then and start looking at whether we need to create new policies within our current system, whether we need to create new resources templates to help with this. But this is an example of what they are likely to look at as additional topic areas to what is already being considered. So as I mentioned at the start, we contributed to the CQC consultation. We had a look at it in detail as a business, and we submitted a response to that consultation, highlighting a few areas of concerns, a few questions that we wanted answered. And one of those was around the KLOEs and the topic guidance, as I've just mentioned. So there's no guidance out there at the moment that categorically says what they're going to be looking at underneath it. They give a broad expectation of what the topic areas are, but no precise guidance on whether that's policies, checklists, audits, things like that. And we've also then obviously highlighted that even though that there's 4 dental specific frameworks now, the primary care framework is still quite a vast area. There's still lots of different sectors working under primary care: GPs, pharmacy, optometry, including dentistry. And all of those are quite different within themselves. So, for example, one of the topic areas, end of life and palliative care planning, will not apply to dental. So what we've asked for is specific guidance for each of those sectors within this. Are they going to be clear for us to understand what topics are going to be relevant to us and what KLOEs they're going to be assessing? Also, with regards to the quality statements, as I mentioned earlier, there was 34 quality statements, but they didn't assess all of them. They only assessed 7. So one of the other questions we asked is, are they going to be using all 26 KLOEs when they're using this draft framework in dentistry? Or are they going to be phasing those 26 in over a period of time? Not quite sure yet, but those are the questions we've asked for clarity on. Okay. Secondly, then, we have addressed the rating characteristics gap. So the framework at the moment is built around those mechanisms. Inspectors will be using those rating characteristics to make their judgments. But if those judgments don't apply to dental practices, then what are the inspectors going to be using in their place? Are they going to be using those judgments on an informal basis, but then applying a different output to dental practices, which is the regulations met or not all regulations met? So again, this was quite a key thing because the whole draft framework was based around these rating characteristics with no clear explanation of how that will be applied within dental. So we've asked for clarity on that, and we're hoping we're going to get something back that will explain then how those ratings are going to be used and judged in a dental practice scenario. Thirdly, then, as I touched on in the previous slide, staff safety. So a new topic area that comes in. And my concern is that this crosses the line between the HSE boundaries. So the current memorandum of understanding between the CQC and HSE, Health and Safety Executive, categorically states that CQC leads on matters involving patients and service users, while the HSE categorically involves issues around workers, visitors, and contractors. So this new KLOE potentially can blur the lines between roles and responsibilities between these two regulators. So what we've asked CQC is to clarify how they're going to police this. How are they going to ensure that their inspectors don't tread into the HSE remit and blur the lines then of what's expected of dental practice? So, for example, the HSE remit under the Memorandum of Understanding, again, clarifies that a manual handling injury to an employee from moving or handling patients or items and equipment falls under their remit. That's an injury. Health and safety law doesn't fall under the CQC remit. But there's potential risk that inspectors may start looking at manual handling as staff safety concerns. So how are they going to ensure that this doesn't cause more confusion? And then the CQC remit, for example, they will look at incidents that may have exposed staff to harm, but the principal concern from a CQC perspective is that the greater risk of harm is for patients. So an example is if you are storing cleaning chemicals in a cupboard that's unlocked and located in your patient reception waiting area. So if patients can access that cupboard, then the greater risk is to them falls in CQC remit. But if that cupboard is located in your staff room, then that should be HSE remit because the greater risk is to staff. So we need clarity on this. We want to make sure that the CQC don't start blurring those lines, causing more confusion and causing a bit of a headache for us, not just as a compliance company, but for you as providers as well, going, right, well, what am I supposed to be doing with all this then? Who am I trying to satisfy? And where's the remit end on this? So we've asked for clear clarification on that. And then lastly, then we've asked for information around their reports. So we know that their existing PDF reports transitioned to a HTML report online. We found that these reports were quite difficult to read through. There was a lot of duplication in there. There was a lot of copy and paste sections. It was hard to determine the findings within the report. And it wasn't very clear what was mandatory or what was recommendations as well. So again, we've highlighted this, is there going to be more clarity then on what actually constitutes a breach for a dental provider? What is the actual regulation that they are breaching that they have to address? Or what is an actual recommendation? What is it just that the inspectors are saying, you can look at this to improve, take your practice to a next level, but it doesn't constitute a breach. So we're looking for clearer confirmation on this, clearer continuity and transparency around their reporting to make it clear for us and for yourselves about what you need to do as a fundamental basis line compared to what you can consider doing to take things to the next level. So what you should do now then as providers? Well, as I said throughout this, there is no need to panic right now. The draft frameworks are currently just going through a trial period. They're trialing this now up until the end of October across a few sectors. They haven't clarified just yet that they're going to be trialing this in the dental sector just yet. So you need to just continue as you are. If CQC come knocking on your door in the next couple of weeks, they're going to be assessing you under the current single assessment framework. So you just carry on doing everything that you're used to, putting all that evidence together that you're already familiar with. Don't worry about any of these new things coming into play just yet. We will provide you as a support company with further information once that becomes clear. But for now, continue as you are. The second thing you could do as well is read our article. We have released a formal article on our web pages that covers off more detail around the CQC consultation and what we fed into it. You should also familiar yourself with the draft framework. So the draft framework is available on the CQC website. Make sure you download the correct one, which is the community primary care and community services framework, and just have a look at it. Have a bit of bedtime reading, getting your head around it. It is quite a simple read. It goes through the sort of ratings that the inspectors will be judging practices on. Like I said, we need to identify how they're going to be using those ratings in the dental environment, but it gives you a sort of understanding of where the inspector's mindset will go to. And then watch out for further updates. As I said, they're trialing this at the moment. There's no formal release date of this just yet for dental, and we're still waiting for further guidance to come out. So once we know or see new things coming out of this, once we hear new press releases or news items from the CQC, or once we've got their feedback regarding the consultation, the responses we submitted, we will likely then put more things out there then to keep you informed, to get you ready for this. We will also be looking at all that from an internal perspective here at Agilio, making sure that any new guidance comes out is mapped accordingly within our compliance software, iComply. iComply is where we've got all our policies, so we'll be making sure that they're updated, adapted, especially our CBD training as well through iLearn. We'll be looking at all that, making sure that it's ready for when the new draft framework is prepared to go live. So this is just an initial heads up. Be prepared of what's coming. The new draft frameworks are going to change the way that CQC look at it, but they have said that they're not going to change it dramatically. A couple of new things may come in, as I've touched on with the new KLOE and new topic area, but fundamentally, I think 90% of the framework will remain as it is, and all the evidence will remain as it is, with a couple of tweaks to how they go about it. So don't panic. Keep your eyes open for more information. And that is it. Thank you. So if you have any questions, then please pop it into the Q&A. I'll go through it now and have a look if there's anything I can answer off off the top of what has come in already. Copy of the recording. So all our webinars go on our YouTube channel. So this webinar, any historic webinars that we've done, I've done a few myself over the last couple of years around trends, myth busting, fire radiation. They're all on our YouTube channel. So feel free to browse that at your leisure and have a look. Okay. Okay, do we have an idea when the new framework will start, goes live? We don't. As I just mentioned, they're trialing it up until the end of October. So when October's finished, they're going to release, hopefully they'll release more information about it then and what the next stages are of that will look like. So at the moment, we don't know. We haven't got any clarity on that just yet. Okay, so as CQC registered practice in a building, renting the room, how do we comply with safe for the building? Should that be done in an SLA agreement from the landlord about safety check, fire and Legionella RA and health and safety RA? Okay, so first thing you need to do on that one, and this is quite common, you need to look at your tenancy agreement between the landlord and yourselves. So within the tenancy agreement, they will have different obligations and responsibilities. So if you haven't got that tenancy agreement, dig it out, speak to your solicitors, someone will have it, and ensure you identify with regards to who's responsible for what. You as the tenant will be fundamentally responsible for a lot of things, but it all depends on who's provided that equipment in the first place and whether that equipment maintains just your demise or whether it maintains a lot of the areas of the building as well. If the tenancy agreement categorically states that your landlord or letting agents are responsible for maintaining all that equipment, that still doesn't remove the obligation from you. You still need to have certified evidence that those maintenance checks and requirements and the risk assessments are being done by your landlord or managing agents. So you need to chase them. You need to get copies of those reports, those maintenance certificates, and you need to make sure that any outcomes or outputs, actions that have arisen from those have been addressed by the managing agents as well. So you've got to chase and chase and chase. And we know that this is a problem because a lot of managing agents out there are not as good as what they could be in sharing that information. My advice to you, and the strongest advice I give you, is when you chase on them for these records and evidence, do it over email. Make sure you've got a written chain, because when the CQC come in to inspect, they will look for that. And if you can demonstrate them that you've chased, then that then removes the responsibility from you. If you can't demonstrate that you've chased, that does put the responsibility on your shoulders, unfortunately. So even if the managing agents haven't addressed the actions, as long as you've kept chasing them on those actions and you've got evidence of that, you have satisfied your obligation. Okay, so just chase, be a pain in your landlord's backside. Mind the language on that, but be a pain. Really put the shackles on them. Make sure they're not getting away with doing things that they should be doing. How many years of past evidence risk assessment audits do we need to keep, as long as we're up to date with current audits assessments? I asked CQC inspector in 2022, visited, and she said 2 years. That seems short. Okay, so risk assessments remain relevant for as long as they are active and applicable to your practice. So if you've got your initial risk assessment done in 2019 and you have reviewed the outputs of that risk assessment and nothing has changed in it, that remains relevant. If you have changed the risk assessment due to a large refurbishment or anything, then that new assessment becomes your evidence. So the old one can essentially be discarded. However, this is a key thing. Under a claims perspective, if a member of your staff was injured at work, they've got up to 3 years to claim on that. So whilst there's no legal obligation to keep a risk assessment once it's replaced with a newer version of that, you have still got to provide evidence to defend yourselves if a claim is brought against you for personal injuries. And because they've got a three-year window for those claims, you should try and keep as much evidence as possible to demonstrate the situation that your practice was in when that injury occurred. So ideally, you would want to have your a copy of risk assessment for that time the injury occurred. So it is a bit of a grey area, this one. Legally, you don't have to keep it for longer than absolutely necessary, but for the purposes of demonstrating evidence in the event of a personal injury claim, you should try and keep evidence for a minimum of 3 years. We have got a record retention schedule in iComply, and if you're not a member of iComply, that is something that you should look at getting in place. A record retention schedule is required. It's something that the inspectors will look at, and it should list everything in your practice that you hold and how long you should be keeping those documentations for. So HTM 0105 has specific recommendations in it for different retention periods. You've got the NHS Code of Practice for record retention documents in NHS providers, which private practice should be following as well. So you've got all this out there, and you should have your record retention schedule in place that lists all of this. Is there any feedback from inspections around the Tier 2 of the McGowan training? As yet, no. We haven't seen any categoric feedback from inspections on this. It's quite vague, it's quite general. They just look for training on autism. They don't categorically state at this moment in time whether Tier 1 or Tier 2 is what they're looking at. We have, however, done an article on this. It's another article up on our website. We've explained the Tier 1, Tier 2, and what is applicable for dental practice. So please feel free to jump on the Agilio web pages, dig out that article, and have a look at it. It explains everything. It explains what you should be doing around that. And I think that's it. So thank you very much for your time. I will leave you with that and have an enjoyable rest of your day. Thank you.